Okay, so welcome to the session on optimal colonoscopy technique. Myself here is the head moderator, and I'm standing next to Ralph Bishops. We have joining us virtually, we have Roland Valori, and we have John Anderson. So this is John Anderson, you can see here. And can we see Roland Valori? Maybe we can. Maybe right now we can't see him. Okay. So welcome to you both. I would like to just take a bit of time to introduce this session. So optimal colonoscopy technique is all about, well, it very much depends on what context you perform colonoscopy in, but it's very important to make sure that you're seeing everything and that your patient is comfortable. And of course, if you're performing under general anesthetic, then your patient is likely to be comfortable. But lesion detection and particular detection of adenomas and the prevention of colorectal cancer is the reason why we are performing colonoscopy. The two virtual moderators that are joining us, who will give now their lectures, are experts in the technique of colonoscopy primarily, although they certainly have other hats.
My name is John Anderson. We're going to do a diagnostic colonoscopy on a 77-year-old lady who's presented with diarrhea and abdominal discomfort. But what I want to focus on is the intubation. Firstly, the setup. I have the patient already on the trolley. She's had some sedation. I've done a PR. This position of the stack is such that the umbilicus is opposite the anus, and really this maximizes the maneuverability of the left hand. It keeps this hand free and loose, and if you do need to transfer loops from the shaft to the instrument and the umbilicus, there's space to do so. So this lady is lightly sedated with just a little bit of midazolam, and she's aware she may have to roll. So the first thing we do is we put the tube in. I'm going to pull back. I'm going to pull back to the dentate line, just to see if there's any pathology at the bottom end. Some people will retrovert right at the beginning. I tend to leave that to the end, but I do like to make sure I've not missed anything right at the start. And you can get a really good view in antegrade. Next thing to say is that in the rectum, I think fluid's poorly tolerated, so what I would normally do would be to take the fluid out of the rectum, if there was any there, and just intubate the rectum with a little bit of air. So here we're just negotiating up towards the rectosigmoid junction. And then beyond the rectosigmoid junction, I will switch to water insufflation. Some people will switch off the CO2 or the air at this point in time to stop them inadvertently covering the button. Hopefully I won't make that mistake. We shall see. In terms of technique, what I like to do is look at the mucosal folds. So here, the lumen is above us and it's off to the right, and then I get the impression it's then going to turn down. So if we do a clockwise talk, this will naturally bring the scope around, such that the lumen itself becomes more towards 12 o'clock. I'm going to add a little bit of water just to help open this up a bit, and you can see the innominate folds and the grooves. And then we're just turning ever so slowly, very comfortable position. We've got a nice C shape outside, and I'm just going to bring the tip up to center the lumen. You can see some early diverticular disease up at 12 o'clock, and this lumen is now off to 3 o'clock. So I can continue to rotate, but you have to remember as you rotate, it's on an ellipse. So you can only go so far right with clockwise rotation. So we go a little bit right, and then we add a bit of right wheel. And that's the key thing. It's what we call facilitated torque steering. So some torque and a little bit of tip. And I can't see anything, so I'm going to put the near focus on. What this does is it just allows me to see these innominate grooves a little bit easier. And I will often use near focus with underwater. And what that's telling me is the lumen is almost certainly now at about 12 or 1 o'clock. So I don't want to push it any further because I haven't got round the bend. In fact, I'm going to tip up, and at the same time I'm actually going to slowly withdraw the instrument. This takes me away from the mucosa and allows me to see. Add a little bit more water. And I hope you'll agree the lumen's up. And now just a little bit of clockwise rotation brings it to 1 o'clock. And it opens up. Now running parallel to this, I've got the imager view, which is the screen in the bottom left, which is split into a classical AP, looking down on the abdomen, and the lateral view. This just shows you there's a little bit of angulation at the rectosigmoid junction. And I'm just allowing the scope. I'm not moving the scope in at all. I'm just guiding the tip. And a little bit of water. And now I'm going to just deangulate. I put clockwise rotation on before, and I'm going to put a little bit anti-clockwise rotation, and I'm going to release the wheels. And this is effectively beginning to straighten the scope out. Not completely straight, because the anatomy is such that the rectum comes up posteriorly, then heads forward, and then usually heads to the left-hand side. She's quite comfortable, and the left lateral is a good position for retaining water. If you think about gravity, Gravity is pulling water down into this left side, and it will be retained in the sigmoid colon. And adding a bit of water in the sigmoid colon both weights the colon down, stops it moving around so much. It clearly cleans. It probably increases the view. The views here are pretty spectacular, but improves the view. And obviously washes, and if there's any dirt or residual staining of the mucosa, it's often very clean on the way out. So we've just gone around the rectosigmoid junction, and we've probably strained a little bit of the colon on the way in there by just moving the tip and allowing the colon to pleat on the scope. And I'm about to turn the corner here. So sometimes there's a bit of resistance here, and if you want to, you can just mention to the patient they may feel a little bit of discomfort down on the left-hand side. I suspect not, but we could warn her, or I'll get my nurse to warn her. And again, I'm just going to use the folds. It tells me it's to the right. Just to guide the tip, ever so tiny little movements with this left thumb. Just guiding the tip to the right. A gentle pressure with the right hand, not a lot. I can let go of the scope. Very little pressure here. Nice and slow. The water's just helping to distend the lumen a little bit. I'm mindful of the fact that there was some early diverticular, and it may or may not have some more proximally. And just allow the colon to settle on the scope. A little bit of fluid, just give yourself some time to allow that to pleat. And what it does, it keeps everything in a straight line. So we want to keep the scope as straight as possible. You'll notice that the folds are telling you that the lumen is sort of 12, 1 o'clock. So as I go in, I'm rotating clockwise, and it moves towards more 12 o'clock position. I bring the tip up. And this movement of clockwise rotation and tip up is usually the easiest, which is why I think we tend to like to bring the lumen to 12 o'clock. Now, the eagle-eyed amongst you will have noticed that there's an external loop here. So as I've been applying clockwise torque, the scope's naturally formed a little loop on the outside. It's not the end of the world, but if I try and apply clockwise, I'm actually torquing into the bed. I'm pushing this part of the scope into the bed when I apply clockwise torque. This bit begins to lift up, and the whole thing feels very, very tight and uncomfortable. So this is a common fault we see, and you see people going from a nice cigar rolling shape to a fist grip, and it's often because there's resistance on the outside. And we're so focused on the screen, we're not having what I call a wide-angle view. So to reduce this, we can simply transfer this loop through the head of the instrument to the umbilicus. And this is formed by a clockwise torque, so I'm going to rotate the scope towards me. And we're back to a nice C sort of position, or a reverse C, where we can rock clockwise or anti-clockwise. So we've got a loop in the umbilicus, so it's shortened this a little bit. However, the freedom I now have with the scope and the scope tip is, for me, more important at this point in time. And I can take this loop out a little bit further into the intubation, and I'll demonstrate that shortly. So this is probably the sigmoid descending junction. So we just rotate around a little bit again, combination of rotation and tip deflection, and that will be the descending. And as we come into a pile of fluid, this is probably going to be the splenic fracture. So if you think about it, with her in the left lateral, the paracollar gutter in the splenic fracture is down and is filling with fluid. It's a fluid-dependent area. In addition, her transverse colon is also falling down towards the splenic fracture and making the splenic fracture very acute. So the optimal position to open up the splenic fracture would in fact be the right lateral. But I'm going to take a slight shortcut here, and we'll see. I'm going to put her onto her back, which is a compromise. So having moved her, and I just pop around the splenic fracture, I'll just show you. It should be air-filled in the transverse, because the transverse colon comes anteriorly. We're not quite out of the fluid yet. And if I wanted to move the fluid, or I was having a problem, the right lateral would be the way to go. But before we go any further, I'm going to I think this will go around very nicely, but if I was a problem, or I was causing pain, or insertion at the splenic fracture was causing the sigmoid colon to buckle, I would roll her onto her right-hand side to get around the sigmoid colon. Not the sigmoid, the splenic fracture.
John, can you hear me at the moment?
Yeah, loud and clear, David.
Yeah, so thanks so much for providing that beautiful thing. If you had to give, let's say, 2 tips to people who maybe they're not consciously competent at colonoscopy, see what that means, what 2 things should they change in their practice to make their insertion?
But it is slowing down, gets you around quicker, and pulling back more than pushing in. I think we need to think about the colonoscope and the mechanics of how it works. It works much better in a straight line. So pulling back essentially reduces loop and allows the colonoscope to reform in effectively a straight line along the longitudinal aspect of the shaft. And that allows you to push forwards. As we keep pulling back, we straighten the instrument up and then we drive the tip forward. And I think people worry that they're pulling back and they're going to lose ground, but actually they make the whole procedure much longer, because if you don't do that, the loops get bigger and bigger and eventually you end up with a different problem.
Really important.
The second thing is that the resistance on the scope will form a buckle, and the buckle eventually forms a loop. So the slower you push in, the more time you've got to visualize where the lumen is, and you can then direct the tip. And when I'm teaching my kids to drive their car, I say, don't get the car. The same would apply to a colonoscope. Please don't shove the instrument in or insert the instrument faster than you can control the tip. Otherwise, you'll continually crash against the mucosa. And as I said, that will form the scope, and the buckle will eventually lead to a loop, and a loop leads to a problem.
And what I'm doing is I'm coming back in the ascending colon. You can actually come quite a long way back in this position, almost to the transverse, I'd say. So what I'm going to do is I'm going to go in further, right back to where I was, and I'm going to tip deflect fully. I'm using both my controls, maximum deflection and then rotation of the scope to find the luminal view, like that. Bit of wash under the folds.
Is this a routine thing for you, Roland, the retroversion?
I've been doing this for a long while. I really think it helps enormously. You get a beautiful view of the folds. With a scope like this, nice clean bow like this, I can often get quite a way up the right colon, as you'll see in a second. So I come there, rotate, pull back. I mean, look at that. You know, I'm not going to be worried about missing anything on the other side of these folds. And I'm going well back.
You're well beyond the splenic, the hepatic fascia there, I think, aren't you?
Well, or even the transverse. So now the thing you need to be really careful of is when you straighten it out. Do that very, very slowly. I've learnt that lesson. Just orientate myself. It's a bit disorientating after you've straightened it out. You can see how far back I was just then, and I'd pull back away. So I think I was well into the transverse then. I don't